In this video, we'll talk about nuclear medicine gastrointestinal system imaging, particularly focusing on the GI pathology studies. Recall that gastrointestinal imaging can be divided into three categories. You have the GI transit and motility studies, hepatobiliary studies, and all the variations of AHIDA, and then the GI pathology. And that's the one that we're going to be focusing on in this video. So the first study that we're going to talk about is the ectopic gastric mucosa. The most common is the Meckel's diverticulum. This is an outpouching of the small intestine that represents a persistent omphomesenteric duct at its junction with the ileum. It's located in the right lower quadrant within about 2 feet of the ileocecal valve, and it's found in about 2% of the population. 15 to 20% of them contain functioning gastric mucosa. That means that they are actively secreting stomach acid and pepsin and gastrin into the intestines. This is very bad for the intestines because the intestines is more of a basic environment and the stomach is more acidic. And so you're basically secreting stomach acid and things like that that can damage the lining of the bowel. These patients usually present by age 2 with blood in the stool. Sometimes they can lay dormant in the body for a long time, though, and then present later. Adults will typically present with diverticulitis. This is an example of a Meckel's diverticulum. Remember that this is actively secreting gastric juices and hydrochloric acid, all the things that stomach mucosa will secrete, but it's doing it into the bowel. This can lead to irritation, pain, bleeding, ulcers in the area, and even perforation. So most Meckel's diverticulum contain gastric mucosa, causing the lower intestinal bleeding from the ileomucosa ulceration caused by the acid. Your environment in the lower intestines is not meant to be able to withstand the acid that's secreted by gastric mucosa, and so it's extremely irritating to that tissue. This Meckel's diverticulum imaging will allow for identification and localization of ectopic gastric mucosa. Indications would be to localize the functioning gastric mucosa, find the source or the cause of unexplained gastrointestinal bleeding, evaluation of blood in the feces, evaluation of abdominal pain, usually in the lower right quadrant, an evaluation of bleeding, diverticulitis, or an intestinal obstruction. Contraindications of a Meckel's, pregnancy or breastfeeding. Of course, the risks need to be discussed and the benefits need to outweigh the risks. This should be discussed with the patient. And if they are breastfeeding, they can pump and waste it for 24 hours or 48. So it's not an absolute contraindication. Previous interfering nuclear medicine study, an example of this would be a TEC red blood cell study. If the patient had bleeding, or blood in their feces, then they may have been recently ordered a GI bleed study. That would interfere with this test, so there needs to be a period of time in between, usually just a couple of days, maybe up to a week, and then active bleeding at the time of the study. If the patient is actively experiencing a GI bleed, then the GI bleed would be the most appropriate test rather than a Meckel's. Any recent administration of potassium perchlorate, this will block the uptake of the radiopharmaceutical into the gastric mucosa. And then cathartics or bowel irritants within 24 hours. This could lead to a false positive. And then barium studies within 3 to 4 days of the study. That would mean that there is barium within the bowel, which will attenuate the radiopharmaceutical and could lead to a false negative. The preparation for this one, the patient should be NPO for 2 to 4 hours prior to the exam. The patient history should include a history of past bleeding episodes and results of any prior studies. over the bleeding site, any clinical signs of active bleeding, such as melena or blood in the stool, and any recent nuclear medicine studies, especially those using red blood cell tagging. The radiopharmaceutical for emeckals is 99M-Tech sodium pertechnetate. This is straight tech that's unbound. Straight tech that's unbound will go to the salivary glands, thyroid gland, gastric mucosa, choroid plexus, or the testes. Notice that technetium does not go to the bowel normally or the intestines normally, but it does go to the gastric mucosa. This is why it's the radiopharmaceutical of choice for Meckel's diverticulum, because it doesn't go to the normal intestines or bowel, but it does go to the gastric mucosa. It makes it ideal for finding areas of ectopic gastric mucosa. The range is 8 to 12 millicuries for an adult. Pediatric patients, it is based on their weight, but there's a minimum of 250 microcuries needed to get enough counts to do the study. And the method of localization for the Meckels is active transport. This is because the sodium pertechnetate is actively accumulated and secreted by the mucoid cells of the gastric mucosa. There are medications that could be used to improve the uptake of the study. All of these radiopharmaceuticals are optional. There are some protocols that don't require any extra medication. The medications that are listed here are given to improve the sensitivity of the study. They will either increase or prolong the uptake of the technetium into the gastric mucosa, and so they increase the overall sensitivity of the test. The first one is cimetidine. Over the counter, this is known as Tagamet. This helps to retain the straight tech in gastric mucosa, and so if it is in there, it will stay in there a little bit longer, and therefore the activity in it will increase over time. This will increase the contrast in the image and make it a little bit easier to identify a Meckel's if it's present. So the dose for that is 20 milligrams per kilogram given orally. And this is starting about a day before the test. And then the last dose is 1 hour prior to the exam. The next one is pentagastrin. This will stimulate gastric secretion. And so this will actually increase the amount of straight tech that is taken up in the ectopic or any gastric mucosa. The dose of that is 6 micrograms per kilogram, given subcutaneously about 15 to 20 minutes prior to the scan. And then glucagon is another option. Glucagon relaxes the smooth muscle of the GI tract, so it slows the natural movement of things through the GI tract. This theoretically will keep the activity in the Meckel's diverticulum longer if it is there. So that is 50 micrograms per kilogram given IV about 10 minutes after the radiopharmaceutical injection. We'll just kind of keep it there. Another optional medication is potassium perchlorate. Now remember, you can't give potassium perchlorate before the radiopharmaceutical injection because it will keep it from uptaking into the gastric mucosa or ectopic gastric mucosa. But afterwards, it can block the thyroid and reduce the radiation dose to the thyroid. So this is sometimes given in children, more so than adults, but it is not to be used before the study is started, only to be given after the study is completed, to reduce the radiation dose to the thyroid. The adult dose is 250 milligrams, and the pediatric dose is weight-based at 6 milligrams per kilogram. So for the procedure, the patient is positioned supine, that means on their back, on the table, and the camera is positioned over their right lower quadrant of their abdomen. Inject the radiopharmaceutical and require a flow study at 1 second per frame for 60 seconds. Continue to acquire dynamic images in the same position every 30 to 60 minutes. Then you can acquire planar images that are left anterior and right anterior oblique, a lateral, and then posterior image. You do want to have the patient go to the bathroom and acquire a post-void image. This is where you would have another anterior image that's post-void, and then images in the decubitus or upper or upright position can help separate the pathology from the bladder if it is in that lower abdomen area. And if the doctor is, if the Meckel's diverticulum is adjacent to the bladder and the patient is unable to void, then a urinary catheter can be placed to drain the bladder and localize the Meckel's diverticulum. Acquisition parameter for a Meckel's, energy is 140 keV because it is technetium based. The collimator is low energy all purpose. The patient positioning is supine or on their back with the camera in the anterior position. Injection to imaging time is immediate because you're doing a flow followed by a dynamic study and then planar images. Additional views would be anterior, right anterior, and left anterior oblique. A lateral, it doesn't really matter which lateral, but if the Meckel's is more to one side or the other, you would take it on that side. And then posterior, and then repeat the images post-void. And then if it is close to the bladder, you could take a image with the patient in the decubitus position or upright position. Matrix is 128 by 128. When you're doing the flow, it's anywhere from 1 to 5 seconds per frame for 60 seconds. Most of the time, this is taken at 1 second per frame. And then when the images are combined to actually capture that and send it to the doctor, they're combined to 5 or so seconds per frame. So you have less pictures to look at. And then the dynamic is 1 minute per frame for 30 to 60 minutes. And the additional views are taken for 5 minutes per view. To process a Meckel's diverticulum, you'll sum the dynamic images and display them. So when you sum the flow or the dynamic, this is when you combine them. You may acquire them in 1 second per frame or 1 minute per frame. But then when you go to actually image them and combine them to send them to the doctor, you may sum them so that you have less individual images. So this is where you might combine them to 5 seconds per frame or 2 to 3 minutes per frame instead. So you just have less images for the doctor to look at. And then you'll scale them and label them appropriately. A lot of times you'll send that cine image to the doctor so the doctor can actually see it in motion, and you'll scale, frame, and label them. The image findings, any gastric concentration of the radiopharmaceutical outside of the stomach is considered a Meckel's diverticulum or positive for ectopic tissue. And the gastric concentration of the radiopharmaceutical will begin about 5 to 10 minutes after injection. Then it will increase in intensity over time. So positive scan is any focal increased activity in the right lower quadrant that appears at the same time as the stomach and increases in intensity just as the gastric mucosa does. And this should be excluded from the ureteral activity because it is cleared through the kidneys and the bladder, and so you will see activity in the ureters. So this is an example of a Meckel's diverticulum. You'll notice by 5 minutes, it starts to show up in the gastric mucosa and in the Meckel's. There's a little arrow here in the 5 minute pointing to where the Meckel's is. By 10 minutes, you'll start to see it concentrating a little bit more. And then by the 25-minute image, it has increased intensity, and you'll see the stomach and the Meckel's are about the same intensity. So that was it for the Meckel's. Now to talk about some of the lower GI anatomy, just to review that before we move on. The small intestine is made of the duodenum, the jejunum, and the ileum in that order. The duodenum or duodenum, however you want to pronounce it, is right where the stomach meets the small intestine. And then the ileum is right where it meets the large intestine. So in the large intestine, it starts with the cecum, and then the ascending colon, transverse colon, the descending colon, sigmoid colon, and then the rectum. So the transverse colon goes across the top here. You have the cecum down here, ascending, transverse, descending. You have the sigmoid colon down here close to the rectum, and then of course you have the rectum. So for a gastrointestinal bleeding study, we're looking for any abnormal bleeding that's happening within the GI tract, usually in the small or large intestine. The rationale for this is that it's performed in patients with suspected active lower in gastrointestinal bleeding. It's usually in the large intestine, and it will not detect prior bleeding, so they need to be actively bleeding at the time of the test. Indications are just for the detection of the presence of GI bleeding and the site of acute gastrointestinal bleeding. So it helps detect and localize it. Contraindications would be pregnancy or breastfeeding. Now, a gastrointestinal bleeding study is a life-threatening test. If the patient is breastfeeding, they can still have the test. They just need to pump their breast milk and then dump it for a period of time to make sure that the radioactivity has cleared from it. And if they are pregnant and they are actively experiencing a GI bleed, this is life-threatening to the mom and the baby. So the risks and the benefits would need to be explained carefully to the patient, and the patient may want to consent to it. The patient who is not actively bleeding, this is a contraindication just because it will not show up. And then that could interfere with their ability to get the test later when they are actively bleeding. Any interfering nuclear medicine study, this would be anything that is excreted through the bowel or shows any activity in the abdominal area or the bowel. And then a recent barium study, that barium will attenuate the activity, and that could cause a false negative. I do want to say, as far as contraindications go, you also don't necessarily want to do the test if somebody is actively receiving a blood transfusion. That can get a little tricky. You never ever want to draw the blood from the blood bag. You always want to draw it from the patient to be tagged. And then if you are injecting the tagged radiopharmaceutical, you just don't want to use transfused blood for that because there can be other things in there to preserve the blood that keep it from being able to tag to the radiopharmaceutical. The patient prep for that, they can eat and drink their medications as usual. This is one of the few GI tests where they don't need to be NPO. They must be actively bleeding when the radiopharmaceutical is in the blood pool. And the medical history should include the presence of orthostatic hypotension, change in pulse rate from supine to standing, frequency and volume of bleeding, You also want to know if it is dark tarry stools, also known as melena, or if it is bright red blood. Dark red tarry stools or melena is more likely to indicate that it is a proximal bleed. It could be in the stomach or the small intestines, whereas bright red blood would indicate that it is in the large intestine and that it is closer to the rectum. Any current in previous hemoglobin or hematocrit levels, and the number of recent blood transfusions. And like I said, you also want to make sure that they're not actively receiving a blood transfusion when you administer it to them. Suspected location of the bleed and the results of any other diagnostic tests. If they've had a recent colonoscopy or endoscopy, you want to know the current blood pressure and pulse, and then any history of past bleeding episodes, whether they needed transfusions for that, how many transfusions they've had, results of any other diagnostic tests, and then any prior therapeutic interventions that may have occurred. So with gastrointestinal bleeding, there are two possible radiopharmaceuticals. There is the 99M-Tech labeled red blood cells. This is the gold standard. This is the preferred way to image them. You would use 20 to 30 millicuries, and this should be done using in vitro tagging using the UltraTag kit. The reason that you don't want to use in vivo or modified in vivo testing is because the radiopharmaceutical tagging is much lower. And so if you have free tech present, it's going to go to the gastric mucosa or a site of a Meckel's diverticulum if one is present, and that could cause a false positive on the GI bleed study. So you want to use the 99M-Tech labeled red blood cells using the UltraTag kit because that does have a higher tagging efficiency. Another thing with the tagged red blood cells and why they're the gold standard, they will remain in the blood pool for a period of time. This can allow you to bring the patient down later and image them if they start actively bleeding. If they have intermittent bleeding, you could use it to do delayed imaging because it does stay in the blood pool. And then the method of localization for the tagged red blood cells is compartmental because it stays in the compartment of the blood vessels. And the normal biodistribution is everywhere that blood goes. Plus, you also see a little bit in the kidneys and bladder. So you'll see the liver, the spleen, the greater abdominal vessels, some kidneys and bladder, genital organs, and the stomach. The other method or the other radiopharmaceutical that you could use would be the sulfur colloid. And for this one, you would use 7 to 10 millicuries of 99M-Tech sulfur colloid. This is the least preferred radiopharmaceutical because it will only be used for active bleeding. Recall that if you inject sulfur colloid with a patient, it goes to the liver, spleen, and bone marrow. Sulfur colloid is a colloid, it's a particulate. And when you inject it into the bloodstream, your body sees that as something that's kind of a foreign invader, but not something that your body can use for anything. So it readily gets taken up by the cells of the reticuloendothelial system and phagocytized. Therefore, you have a very short window of time that you can image with the sulfur colloid before the activity is localized in the liver, spleen, and bone marrow. So this makes it less optimal for looking at a GI bleed, but it can be used to see if there's an active bleed, because if you inject the patient in that very first initial time frame with the blood pooling, you would be able to see a lead if it was active. The method of localization for sulfur colloid for a GI bleed is compartmental. It's going to be different for sulfur colloid for other studies because it localizes in different ways. The normal biodistribution is the liver, spleen, bone marrow, and genital organs. The procedure for a GI bleed, it consists of a flow. Before you start, you want to have the patient void their bladder and bowel if possible prior to imaging. It's important to note here that these patients are fall risks. A lot of them have low blood levels, or they have blood loss anemia, or they have blood loss hypotension or orthostatic hypotension. And allowing them to get up and go to the bathroom by themselves may lead to the patient passing out, fainting, or falling. And so you don't want to let them go by themselves. It's ideal to give them a bedpan or a bedside urinal. And if not, then you need to keep a close eye on your patient, walk them to the bathroom themselves or yourself. Um, and then you'll label the red blood cells. This takes about a half hour to 20 minutes with the UltraTech kit, but the highest labeling efficiency is using the in vitro method. In vivo should not be used at all. So once the blood is tagged, you'll put the patient on the camera supine with the camera anterior with the field of view over their abdomen and pelvis. The patient will get a flow typically at about 1 to 2 seconds per frame for 1 to 2 minutes. Those images later get added together for display at about 5 to 10 seconds per frame. And then you begin the serial imaging, which is 1 minute per frame for 60 to 120 minutes. So for 1 to 2 hours, you'll take sequential 1-minute images. Activity in the bladder can obscure activity in the rectum, so you would want to take additional lateral views especially if the patient has bright red blood. And then the anterior and posterior obliques are often helpful as well. If the study is negative after initial imaging, then delays may be performed for at 2 to 6 hours or 8 to 24 hours. Note that it is important to continue imaging after bleeding is identified to see it more and identify the site of origin. A lot of times it is vital for the doctors to look at the cine portion so you can see where the GI bleed exactly starts to come from. Bleeding can be seen from the beginning to identify the site of origin. So delayed imaging may confirm bleeding, but not necessarily look at the site. When doing sulfur colloid, it's basically the same, except there's no blood tagging, so you can begin the flow right away. This is a quicker test because then it quickly localizes into their liver, spleen, and bone marrow. So you'll be in flow imaging immediately post-injection at 1 to 2 seconds a frame for 2 minutes. Those can get scaled later up to 5 to 10 seconds per frame. And then followed by serial imaging at 1 to 2 minutes per frame for 30 minutes. After that, the activity in the liver and spleen becomes too bright. Activity in the liver can obscure activity in the right upper quadrant, and the spleen can obscure activity in the left upper quadrant. So anterior and posterior obliques can be helpful. Delayed imaging is not possible when you image with the sulfur colloid because it's cleared from the blood pool quickly and then localizes in the reticuloendothelial cells. Positive bleeding is typically seen within the first 5 minutes of imaging, and it is important to continue imaging even after bleeding is identified to see it move and to successfully identify the site of origin. This is an example of a GI bleeding study. You'll see where the arrow is pointing, you start to see the blood squirting out a little bit. This is one that used tagged red blood cells, and you can tell because you can see the heart here in the top of the image. You see the liver and the spleen, but very faintly, and then you see the greater vessels of the abdomen and bifurcating into the femoral blood vessels. So the arrow is pointing right to the site of the bleed. And as the time goes on, by the end of the scan, you can see that it's much brighter. So when you're imaging, regardless of which radiopharmaceutical you're using, you'll have 140 keV energy with a 20% window. Collimator will be low energy all purpose. You'll have the patient supine with the camera anterior over the abdomen and pelvis. you do dynamic images with flow, and then if you take additional views, you can typically take them for 500,000 to 2 million counts per image, and the matrix is 128 by 128. When you're processing the images, you do want to sum and scale the flow and the dynamic images. Make sure that they are clearly labeled with the time intervals. And then the cine display is essential for the doctors to review so that they can see and identify the site of the bleeding. Blood does move in anterograde and retrograde motion once in the lumen of the GI tract. And this happens very quickly, and it can make it difficult to identify the site of origin. This is the reason that we do dynamic images. And then a positive scan will show up as progressive tracer accumulation that moves in the shape of the GI tract. You'll start to see it moving through the bowel. If the patient is positive, it may be transferred directly to interventional radiology to catheterize or embolize that site of the bleed. And the patient with an acute GI bleed may rapidly become unstable, so you'll need to constantly monitor them for hypotension and never let them get up and go to the bathroom by themselves. If they are getting up, they need to sit up slowly and then sit there for a minute to make sure they're not going to pass out. Poor quality labeling of the red blood cells can lead to uptake in the gastric mucosa and may stimulate upper GI bleeding. This is another example of GI bleed imaging, and this is a good one to show how it quickly moves through the bowel. You'll see in the initial image, you start to see it squirt out a little bit there into the bowel. And then by the last image, you see that it has started to move through the intestines and you see it more elongated. It makes it difficult to see the site of origin. And this is another one that shows how quickly it can move through the bowel. In the very initial image, you start to see the site of the GI bleed, and then you see it localized more intensely, and then you start to see it moving through the bowel. And by the time that it gets to the end, it is very difficult to see where the original site came from. This is an example of a false positive for ileal varices, or basically is staying in the vascularities and concentrating there. This is just like varicose veins that are in the ileal area, and so that's why you see it's a little bit more torturous and complicated blood pooling. And that's it for part 1 of the pathology imaging with GI bleeding and Meckel's diverticulum. And I will upload another video where we talk about liver hemangioma study, liver spleen scan, and the HAPS procedure.